today we're going to discuss about the cerebellum. Okay, cerebellum belongs to forebrain, is it not? Forebrain or nine?
Yes,
Hindbrain. So cerebellum belongs to hindbrain. Okay. So what are the other components of hindbrain? Medulla oblongata. So obviously the cerebellum is situated behind the pons and medulla oblongata, not behind the midbrain only, right? Behind the pons and medulla oblongata is the cerebellum over here. So both these three structures are separated by means of a triangular cavity over here, that is nothing but
fourth ventricle.
Fourth ventricle over here. Come on. Okay. So this is a cerebellum which is located in the anterior cranial fossa. Is it not right? Posterior cranial fossa. Okay. Because for the posterior aspect it is present, so that's why the cerebellum is present in the posterior cranial fossa, just below a fold of dura mater. What is it?
Tentorium
cerebellum. Okay, right. So what is the? Why do we need the cerebellum? What's the need of the cerebellum?
Equilibrium between the body.
Coordination of movements and then
Equilibrium of the body.
equilibrium of the body. Tone of the muscles over here. What is the tone of a muscle? What is the tone of a muscle?
Resting position में muscle. Resting position में muscle. Muscle keep the contact करता है.
Passive. Okay. Passive. What is that? Passive contraction. Why the passive contraction is needed? That means whenever you are resting, your muscle will be showing some tension in that. What for that tension is needed even when you are resting. For example, you are sleeping nicely. Okay, after having a nice period, you are sleeping nicely. So in the middle, for example, you got a sudden emergency. What you are supposed to do? Immediately you are supposed to get up and then you are supposed to go on, right? So for that sake, every time the muscle must be alert. So that alertness is nothing but the tension of the muscle. Okay, that is the resting position. Okay, whenever you are sleeping or whenever you are lying on your bed over here, that resting position, the muscle will be having some tension. That is nothing but the tone of the muscle, which will be maintained by the cerebellum over here, and that leads to action, further action. Okay, that action will be coordinated and equilibrium. The equilibrium will be maintained and the coordination will be done by the cerebellum again over here. So that's why we need the cerebellum. Why coordinated movements are needed for our body? Why not individual movements? Why only not only? Why coordinated movements are needed generally?
The complex. Complex का कर दो.
Why coordinated movements are needed? For example, if you want to look towards that side. Okay, for example, RCA Mamta, he has come over that side, so you want to look at him. So you are supposed to turn both the eyeballs towards that side. Is it not right? So if for the movement of these eyeballs, which ones are acting over here? For the right eyeball, lateral rectus is acting, and for the left eyeball, medial rectus is acting. So if the medial rectus says that I won't work, what will happen? What will happen? Only one eye will be turning over there, the other eye will not be turning over there. So the field of vision will be missed over. Is it not right? So for that sake, the coordination of movements is needed over. Let me not right? For example, for writing purpose, if I am drawing over here this manner, so both the extensors and the flexor muscles will be coordinated over here. So if the flexor muscles are contracting over here, my extensor muscles must be relaxed over here. Same vice versa over here. This is the coordination of the movements with respect to the flexor and extensors over here. So if with one movement will not occur, the other movement will be hampered, okay, or restricted. For that, the coordination of the movements are needed over here. Okay. So this is the basic function of the cerebellum over here. So The cerebellum, we are going to discuss only the gross anatomy, not the entire internal connections and everything. Okay. So the gross anatomy of the cerebellum. Okay. So this is the dorsal aspect of the cerebellum, just behind the brainstem over here. This is towards the posterior aspect. So this is what we are looking at, the posterior aspect of the cerebellum over here. Okay. So this cerebellum contains two parts. What are the two parts? The cerebellum, of course, what are the two parts of the cerebellum generally as a whole? It contains cortex and medulla. The cortex contains folia and fissures. What is folia and what are the fissures? Just like the gyri and sulci of our cerebral hemispheres, we are getting the folia, which are the elevations, and the fissures, which are the depressions. So here are the sulci. What for these folia and fissures are needed in case of cerebellum?
To increase surface area.
Increase the surface area. Increase the surface area so that it can accommodate multiple things over. Okay, right. So that is the cortex which is situated on the outer aspect or superficial aspect over, which contains the brain matter. Is it not? Which contains the brain matter. Okay. And then followed by the medulla. And then followed by the deeper core of this entire cortex is nothing but the medulla. Okay, that medulla contains both ascending and descending nerve fibers over here. Nerve fibers, nothing but the axons over here. Okay. So this is a medullary core over here. And the folia and the fissures will be arranged in this manner. Is it not? So this is the medullary core, the ascending fibers or descending fibers over here, which forms the middlemost portion of this entire cerebellar hemispheres over here, and around which is the folia and the fissures. These elevations are the folia and these depressions are the fissures over here. As a whole, it looks like a leaf or tree branching pattern over here. That's why it is also termed as, this terminology is important. Arborvitae cerebelli. Arborvitae cerebelli. Arborvitae means tree of life. Tree of life. Okay. So it appears like a tree branching pattern and the leaves over here. That's what it is termed as an arborvitae cerebelli. This term will be asked in the examination. Okay, arborvitae cerebelli, why it is so? Okay. And the cerebellum contains two things over here. So in the center there is a worm-like structure over here. Okay, come on. So the cerebellar hemispheres, first of all, the cerebellar hemispheres on either sides over here will be containing a deeply seated nuclei. Deeply seated nuclei within the medullary core over here, not in the cortex. Few nuclei are situated within the medulla over here, which are paired nuclei. Few nuclei will be on this side, few nuclei will be on that side. Similar nuclei. What are those nuclei from median to lateral? Median to lateral must be knowing already.
Vestigial nuclei.
Alright, nucleus.
Vestigial nucleus.
Fastigious, exactly. Fastigious.
Then globus.
And followed by nucleus.
Globus emboliform.
Globosus. And then followed by nucleus.
Emboliformis.
Emboliformis. And then followed by nucleus.
Dentate.
Dentatus. These nuclei you are supposed to remember all the way from medial to lateral direction. What are the nuclei? Nucleus fastigious, which is also termed as the roof nuclei. These nuclei are situated on the roof of the fourth ventricle over here. Okay, and then by the side will be the nucleus globosus, and then by the side will be the nucleus emboliformis. Further lateral will be the dentatus nucleus over here. Dentatus means obviously the like a teeth-like thing. Right? So the middle two nuclei are termed as the interpositus. Why? Because these are the middle part of the two nuclei over here. These are the middlemost nuclei. That's why these are termed as a nucleus interpositus. Okay, these nuclei terminology will be asked in the examination. Okay, the connections will be discussed later. Okay. So these are the deeper nuclei which are situated in the cerebellum. Now we are focusing on the main gross structure of the cerebellum over here. So the grossly the cerebellum is divided anatomically subdivisions of the cerebellum over here. What are the anatomical subdivisions of the cerebellum? Whenever you look at the cerebellum, you'll be finding two structures over here. One is a centralmost worm-like structure that is nothing but the vermis. Exactly. And then on either side, these two are
Hemisphere.
what's it?
Cerebellum hemisphere.
Cerebellum hemispheres, of course. We'll see that coming later. Okay. So these are the two cerebellar hemispheres. In the center is a vermis over here. So beneath everything, you're finding a separate lobule over here. Okay, separate lobe over here. So what is this lobe is termed as?
Flocculonodular lobe.
Flocculonodular lobe. Okay. Flocculonodular lobe. This is a nodule and these are the flocculi connected by means of a peduncle and inferior medullary venum. Superior medullary venum over the roof of the fourth ventricle, which is made up of white fibers over here. And the inferior medullary venum over here, that is made up of what is biomembrane. Exactly. What is biomembrane? It is made up of biomembrane. So obviously the blood vessels will be present over here. Okay. Sorry, not biomembrane. Ependyme. Ependyme, not biomembrane. Ependyme. Ependyme means? Ependyme means?
Ependymal cells.
Okay. It's a squamous cells which lines the blood vessels. That is nothing but the ependyme. Okay. In the same cells which lines the peritoneum, that is termed as mesothelium. These are the basic things also. The names are different, but the structure is same. Okay. So these are made up of ependyme over here. Okay. So obviously made up of blood vessels over here. Getting it out, right? So this is the caudal part. This is the caudal part over here. Getting it out? This is the caudal part. So this entire upper portion is termed as the corpus cerebellum. This entire is termed as the corpus cerebellum. Okay, corpus cerebellum. So the lowermost, the small lobe is nothing but the flocculonodular lobe. It's a separate lobe over here. And this entire upper thing is nothing but the corpus cerebelli over here. Getting it out? This corpus cerebelli contains the vermis and the cerebellar hemispheres. Okay. Vermis and the corpus, cerebellar hemispheres over here. The vermis is divided into multiple small parts over here, segments over here. You are supposed to know the names, which will be asked in the examination. Right? So what are the names of somebody? What are the names of these things over here? This one is nothing but exactly what's that? Lingula and followed by central lobule and then further culmen, right? And then further incline and then further folium vermis and then followed by further tubal vermis and then further pyramid and then further you know very good. So direct look at the what is so once again, all the way from above downwards, you are supposed to remember what it was. Lingula. Below that will be central lobule. Everybody, just like the kids, repeat it along with me. Lingula, central lobule, decline, folium vermis,
Tuber
vermis,
pyramid
and okay, everybody repeat it up, right? Okay, everybody clear or not? Everybody should remember these things, okay? So these things are connected to the lobules of the cerebellar hemispheres over here, and you are supposed to know the names of these lobules. If you consider each and every cerebellar hemisphere as a lobe over here, that will be divided into multiple lobules over here. So what are the lobules over here? Mainly, of course, then quadrangular lobule, and then further lobulus simplex, and then further by superior semi-lunar lobule, and then followed by inferior semi-lunar lobule, and then followed by these you are supposed to remember. Okay, what are those? All the different above downwards. The central lobule is connected to the AD and then culmen with the quadrangular lobule over here and then decline with the lobulus simplex over here and then further by folium verbis with respect to the superior semilunar lobule and then tuber verbis with the inferior semilunar lobule and pyramid with the biventral lobule and below that with the uvula-medius with the tonsil over here. These are the connections in between these adjacent structures over here which are supposed to remember. Okay. So these are the anatomical divisions over here and further will be you see here the lingula doesn't have any lobules on either sides. Lingula doesn't have any lobules on either sides. Okay. So this corpus cerebelli will be divided into anterior and posterior lobes. What are those? Anterior and posterior lobes. So anterior and posterior lobes is formed by means of a fissure over here. That is nothing but the fissura prima or primary fissure. Fissura prima or primary fissure. Fissura prima or primary fissure divides the entire corpus cerebelli into anterior and posterior lobes over here. Okay, so that is the fissure which is present in between the what is this culmen and decline over here and also between the quadrangular lobule and lobulus simplex over here. So this is the fissura prima which divides this into anterior lobe above and posterior lobe below over here. Getting it over? One more fissure that is nothing but the horizontal fissure. This fissure divides the entire corpus cerebelli into two surfaces. One is the superior surface, one is the inferior surface over here. Okay. If you see on the side over here, this diagram. Okay. So this is the pons over here. We put it in the middle of oblongata. You can see that this is the superior surface and this is the inferior surface of the cerebellum, corpus cerebelli over here. Those two surfaces are divided by means of a fissure over here that is nothing but the horizontal fissure. But it is divided into anterior and posterior lobes by means of fissure called fissura prima. Fissura prima is the horizontal fissure over here or primary fissure over here. So small anterior lobe and rest of the thing is the posterior lobe and this is the superior surface and this is the inferior surface over here. If you see properly, the anterior lobe belongs to which surface? Anterior lobe belongs to which surface? Only the superior surface. But the entire posterior lobe belongs to both superior surface and of course the inferior surface also. Getting it or not? So these are the anatomical subdivisions into the vermis and the cerebellar hemispheres and also anterior lobe and posterior lobe and superior surface and inferior surface over here. Now, morphological subdivisions. Morphos means what?
External structure.
So these are the three morphological. What is the what? External? So you proceed external?
Section.
What is it?
Feature.
What? Morphos means what actually? Form of a particular structure. Right? What is it? Okay, phylogenetically you can say that. Okay. But basically the morphos means that the meaning is form of it. Okay. So morphological what's the subdivisions are archicerebellum, paliocerebellum and neocerebellum. So what are the difference between these terminologies? Archi means what? Palio means what? And neo means what?
New money new.
Phylogenetically, what are the differences?
Archi means old. Something oldest.
Archi means-
bacteria.
Archi means
Old.
old age, just like me. Okay, and then
And then major cerebellum. Then paleo.
paleo means old. Archeo means old. Paleo also means old. And then followed by
New money new.
neo means new. Just like you people, neo means new, right?
Paleo कैसा है?
Okay. So to say something is old, there must be a beginning. Is it not? Right? There must be a beginning, right? So archi means it's the beginning. Of course, it is old, but it is the starting point, beginning. And then paleo means ancient. Just after the beginning, this is the oldest, ancient over it. And the neo means obviously the new thing over it. Okay. Among this entire cerebellar hemispheres of the worms, few structures belongs to the archicerebellum and paracerebellum and piocerebellum. Okay. What is the basic function of these cerebelli over here? These cerebelli controls actually the posture, tone, and equilibrium of trunk. Okay, so what is the basic difference between these three? Archicerebellum deals with the posture, tone, and equilibrium of the trunk muscles over here. Only the trunk. Getting it over? And the paliocerebellum is concerned with the limbs, both the superior extremities and the inferior extremities over here. Right? So as a whole, it will be supplying the entire body. These two will be supplying the entire body. That means the muscles will be maintained by means of these two cerebelli over here. And then further, coordinated movements, nothing but the skillful movements will be done by neocerebellum. Is it not right? Neocerebellum. So, what among these few structures belongs to different cerebelli over here? First of all, easy to remember, archicerebellum is the beginning and the ending over here. Archicerebellum is the beginning and the ending, nothing but the lingula and the flocculonodular lobe belongs to the archicerebellum over here. Getting it out? Beginning and the ending over here. Archicerebellum, lingula and flocculonodular lobe. Then further, paliocerebellum again the beginning and the end over here. Getting it out? What are this blue colored highlighted structures belongs to the paliocerebellum over here. What are those? The alae, quadrangular lobule, and then this provides central lobule and the culmen, along with the pyramid and uvula belongs to the paliocerebellum. So lingula and the flocculonodular lobe controls which part of the body? Trunk. So these two structures and these two structures will be controlling the limbs over here. And the rest will be controlling the skillful movements of all these things over here. So as you can understand, whenever the cerebellum is emerging, it is separating the middle portion. For example, if it is growing in this manner, it is separating the upper and lower portions in the manner. Could you understand? Right? So this neocerebellum is emerging behind and separating the upper portion and lower portion. Nothing but the paliocerebellum above, paliocerebellum below in this manner. So initially this is the beginning one. So these two are separated by this thing over here. And this neocerebellum is separating the paliocerebellum part of it. Could you understand? That is the developmental thing. Okay. So these will be controlling the different structures, posture, tone, and equilibrium of the trunk over here. Okay. So cerebellum will be controlling all this posture, equilibrium, and tone. For that sake, it needs a sensation of it. It needs a sensation of it.
Yes, sir.
So, what sensations it can take, and what process will be occurring within the cerebellum? Outline, only the skeletal part. Outline, just outline. No need to describe each and every connection. Unconscious patient. Proprioception. Unconscious patient. Unconscious patient. Proprioception. Okay. Unconscious allows you proprioception. Very good. What's that way? Say it. Unconscious proprioception. Okay? What's that way? Unconscious proprioception. Together. Unconscious sensation, along with proprioception sensation. What? What can you Oh, okay. Conscious and unconscious you are saying. Okay. Fine. That's good. Okay. So what are the sensations? Normal, generally, unconscious and conscious. What sensations you can get? What sensations? Pain, temperature, touch, any other?
Vibration.
Pressure, okay, vibration sense, any other?
Stereognosis.
Stereognosis. What is stereognosis?
Ability to identify any structure by just
Ability to identify an object by
touching.
closing the eyes by touch. Then, any other? What special senses? Facial?
Vision.
Vision
Taste, olfaction.
Hearing?
Vision, taste, olfaction.
So all these sensations are getting over here. So how it will process the sensations? What it does basically? So for example, a student, a notorious student for example, okay. So who fell in his or her homework, okay, who lost consciousness, okay, is brought to our BMC casualty or emergency room over here, and you are one of the doctor over there. Okay, your junior would have fell down. Okay. So the cause of her unconsciousness is the parents didn't buy the smartphone or whatever it might be, gold ring or whatever it might be. Okay. So what happened? He or she, no, not he, basically the right. Okay, fine. Okay, right. So she has been brought to the BMC over here. So you are the doctor. So how you will get the history? What the history means? What has happened before this unconsciousness? How you will ask? You will ask the unconscious patient that what will happen? What happened here? Then what? Patient party. Patient party, exactly. Okay. So who are the bystanders of the patient party? They're standing beside her. You will be asking. They will say some whatever the history might be. So then, how you will approach the patient? How you will make her conscious? So actually, she is not unconscious. She is conscious, but is acting like an unconscious patient over here. So you can make awake the unconscious patient, but not the conscious patient, acting as an awake patient. Is it not? So for that sake, how you will evaluate? First of all, tapping or touching over here, and then you will be telling him or her to wake up. So if it is not possible, what will you do? You will pinch the pain, touch initially, then pain, and then pressure. Pressure at here or somewhere, more points. Touch, pain and pressure over here, even though she is not getting up over here, and then what you will do? What you will do?
Shake the person.
Nicely, you can slap. Is it alright? So that leads to touch, pressure has already over, of course pain we have given, and one more pain, that is nothing but the slapping of the patient, but still she don't want to get it, don't come into consciousness over here. Then what you do? Water, how this water thing will go? Temperature? Cold water? So whatever he said was right. So actually the cold water thing is related to temperature, but what's the main mechanism, basic mechanism? So simple, very simple. So just if you sprinkle the cold water over the face, the tactile receptors will be receiving the sensations, and the face is received by which nerves over here the sensation? The trigeminal nerve. The trigeminal nerve will be carrying all the sensations towards the water. Sensation will be received back to which nucleus?
Trigeminal nucleus.
What right? sensory nuclei of the trigeminum, which is situated in the
Brainstem.
of course, big brain bonds and middle of optic. These also sensory nuclei of the trigeminum is situated. So which will be received. That is belongs to the trigeminum. That's a different thing.
वो फिर तीन भाग से
And then what about the cerebellum? What about the cerebellum? Whatever the sensations you are giving over here will be taken by the spinal nerves and everything over here, and then that will be carried to the cerebellum, and then further it will be processed within the cerebellum, and that will be carried the sensations to the cerebral cortex. Is it not? From there the motor activity will be produced over here. So if I am the doctor which is standing over there, what I will do? I will tell to the patient that so if there is any problem in the brain, so what will happen? So automatically the hand or leg will be lifted up in this manner. Getting it or not? What will happen? If there is a problem in the brain, automatically the hand and the leg will be lifted up, or it will be moved unconditionally. Okay. So generally it will not happen actually. Okay. To make her awake, I am telling the lies over here. Okay. So what will happen? As soon as I say, if she lifts up the hand and the leg, that indicates that she is faking the unconsciousness over here. Would you understand? Would you understand or not?
Yes, sir.
Right? Right or not? Would you understand or not?
Yes, sir.
Would you understand or not? Right? So in case of this is a conscious patient. So whatever she is hearing over here and whatever touch what I am giving over here, she could be able to sense. But she don't want to produce the motor activity over here. But if it is really an unconscious patient, what will happen? If you sprinkle the water or if you give the pain or temperature, whatever you do, automatically the patient will gain the consciousness and he will react according to the situation over there. Getting it or not? So even during unconsciousness also, everything, the senses will be processed within the cerebellum and the motor activity will be produced over there. Of course, obviously the conscious thing also will be happening over there. In consciousness also, you will be getting all these things and coordinated movements will be produced. For example, if a student is sleeping, okay, what I should do? What I should do? What I should sorry, come on. What I should do? What I should do? Yeah, obviously. If I throw a chalk piece over him, obviously he will react accordingly. Okay. So these are the things which will be done by the cerebellum. Like now you can understand all the senses will be received by the cerebellum and it will process or integrate together and that will send to the motor cortex over here. So automatically the motor activity will be produced over here. Getting it? This is the basic or the process which is happening within the cerebellum, right? So if there is a lesion or any injury to these parts of the cerebellum, either paracerebellum or neocerebellum or orchicerebellum, what symptoms or what signs you can see within the patient? There will be loss of tone of the muscles over here, first of all, then followed by what? No, it's okay. Basic things. Basic things. Mainly these are concerned with the tone, posture and equilibrium. So tone will be lost. What is it? Adduction? Ataxia. We'll discuss that. We'll categorize into multiple things later on. But basically, if there is a lesion over here, the tone will be reduced over here. And then followed by the equilibrium will not be maintained. Just remember, tone will be reduced over here and the equilibrium will not be maintained and coordination of movements also will not be maintained. Nothing but a skillful acts over here. So let us categorize more. First of all, coming to the archicerebellar syndrome. So archicerebellar syndrome, which part of the cerebellum must be damaged over here?
The lingula.
Archicerebellar.
No, lingula and the polygonal. No, the lingula or the
Oculonodular lobe. If those getting damaged because of either tumor or any injury, external injury, or because of the blood clot, which supplying these, the cerebellar arteries which are supplying these things over here, it's blocked over here because of the ischemia and necrosis. There is a damage to these structures over here. The lesion, that leads to the lesion, that leads to the symptoms and signs. So what symptoms and signs you can get over here? So because the archicerebellar cerebellum is concerned with
maintenance of tone, muscle
tone, posture and equilibrium of
trunk.
So what will happen to the patient? This is generally seen in the children. So what will happen?
Swings from side to side. Swings from side to side.
It's okay. The swaying is okay. That is the lesion. So what will happen basically? The archicerebellum is mainly
Equilibrium is disturbed.
managing the trunk muscles. Is it not? So what will happen to the patient? What will happen to her? Exactly. he or she can't able to stand because the back muscles and the front muscles should be balanced over here. So then only the patient will be able to stand. If one thing is absent over here, so obviously the patient will tend to fall, and the front or the back. Getting it out? But what happens to the limbs?
Okay.
What happens to the limbs?
Limbs work okay, sir.
What is okay?
Limbs are normal.
Limbs is normally working over here because the rest of the cerebellum is intact over here. So what is the reflexes and everything? Everything are intact over here with respect to the limbs, not with respect to the trunk. So at the same time, what will happen? The patient tries to walk because of the loss of equilibrium over here. What is it? Swaying of the trunk will occur in this one. So the body will be falling on this side or that side. Don't mind, I'm not dancing over here. Okay, right? Okay. So the body will be swaying in this manner because of the loss of equilibrium and coordination of the muscles of the trunk over here. Getting it out? So to balance this part over here, so what the patient will do, not the children, what they will do. In adults also, what they will do to balance this weight, what they will do.
Big steps.
So the patient will be walking with a wide base gait. That means the broad base gait. That means whenever you are stepping in this manner, putting the limbs away from each other, this is the broad base gait over here. So what will happen? The patient is swaying on this side, he can control with this limb. And if he is swaying on this side, he can control with this limb. So then he can walk in this manner. Getting it on? This is the broad base gait over here. Got it right?
Yes, sir.
So this, if you see the children, then you can say it as cerebellar syndrome over here. Getting it over? So the posture is not maintained over here, equilibrium is also not maintained, and tone is also not maintained with respect to the trunk over here. Got it? Coming to the Cerebellum. Cerebellar syndrome generally seen in alcoholics and malnutrition generally. So just remember. So further categorization over here is generally this will be seen in the children over here, and this cerebellum is seen in alcoholics and malnutrition patients over here. And also you can see in malignancies or the blood clots or in case of direct injuries also you can see. But basically these, as soon as you see an alcoholic, if he is behaving some abnormal, you can think of this cerebellar lesion over here. Whenever, as soon as you see the patient. Getting it? So, somebody show me how the alcoholic walks, right? If you have never seen on the road or in the movies. So, both the girls and guys are accepted. Volunteers. So the cerebellum is concerned with loss of which activity? Limbs over here. So superior extremities and inferior extremities. But the trunk will be intact. Is it not? So what will happen over here? Normally if you walk, you will be walking in this manner, right? Right. So the coordination will be missed over here. Whenever you are walking with the right leg, automatically your left hand will move straight. The same manner, opposite to that. So how the drunken people will walk?
Incoordination.
Like this. So the hands and legs will be going on this side or that side. Don't think, right? Don't think I'm dancing.
Great move.
Okay, once I just show that you remember that, so I'm showing all this again. So the hands and legs will not be coordinated over here. Again, the alcoholic patient will be using the broad base gait or wide base gait over here to control the coordination. Getting it over? If the limbs are not in control, automatically the trunk will move here and there. Isn't it? Right? So for that side maintenance, you will be walking on a broad base gait. Both the cerebellum and cerebellum, the commonest thing is the broad base gait. Whenever you are seeing these gaits over here, you can think in case of children, you can think about the cerebellar lesion, and in case of adults, alcoholic and malnutrition over here. And coming to the neocerebellum, your favorite, you must be knowing already, somebody saying attacks and everything. So by these movements, can I become a dancer? Say it. By these movements, can I become a dancer? Right now. So neocerebellum, first of all, the toe. So what will happen to the toe? Diminished. So what is the diminution of toe is termed as
Hypotonia.
Hypotonia. How can you elicit the hypotonia? This is a pendular lesion. You said, what is the pendular lesion? You must be knowing very well. Physiology. What is it? What is it? Patellar tendon. What will happen? So how you will do? How you will do to the patient? In what posture the patient must be lying or sitting? Sitting and not in lying down. So if an unconscious patient comes, so you tell that unconscious patient to sit, to sit the knees are covered. No. Then how? Yeah, exactly. What is it? The knee must be flexed on one hand and you will be tapping with the other hand only. The leg will be lying in this manner. The supine posture. If it is conscious, you can make him sit and you can do that. What will happen? Normally the knee jerk gives rise to normal person. The knee jerk gives rise to what the action you will elicit. Extension of chest because of the tension tone of the muscles over. Okay, but in case of hypotonia, what will happen?
No extension.
There will be pendular knee jerk. What is pendular knee jerk? As soon as you tap on the what is the tendon, right? Achilles tendon, right?
No.
What will happen? The limb will be moving like a pendulum, oscillatory movement because of the hypotonia. Both the flexors and extensors are hypotonic over here, so it will be moving like a pendulum in this manner, not like extension, pure extension. Getting it out? Actually, this tendon is concerned with the extensor muscle group over here. Because of the hypotonia, it will be swaying here and there in this manner. That is a pendular knee jerk. Okay. Then followed by asynergia. What is asynergia? Synergia means what? Synergistic means what?
Same kind of synchronous.
What is
Synchronous.
No. Synergia means what? Synergistic means what?
Synchronous.
Right? But what is synergistic means?
Synchronous.
Absolutely. The coordination. Okay, synergistic means the coordination. Asynergia means
No coordination.
loss of coordination over here. Okay. So, among the synergistic things, there is antagonist and agonist. So, what is agonistic and antagonistic? Agonistic means what? So, me and you people are agonists or antagonists?
Agonist.
Agonist. In what sense? In what sense? Agonist.
Yeah.
What is agonism means? Agonistic means what?
Working
What's it?
health workers.
Against? Agonistic means against.
Antagonist.
Agonistic means who supports each other. Right? Antagonistic means opposite. So I will be agonistic in the class and antagonistic in
Opposite.
opposite. Yeah?
Opposite.
So I am antagonist now.
You're agonist now.
Agonist now. and
Antagonist in the private.
Very good. Very nice. Okay. So agonistic, okay, and antagonistic over there. Okay. See, one muscle group are acting over here, the other muscle group will become antagonistic. So this is agonistic. All the muscles, flexor muscles are agonist to each other, but the extensor will become antagonist whenever the flexion is happening over there. Is it or not? So asynergia means incoordination or loss of coordination over here. What are the different things you can get in the incoordination over here? What are the different things over here? Ataxia, very good. Ataxia. What is ataxia means? Taxis means what? Taxis means what? Chemotaxis, neurotaxis.
Movement.
Okay. Ataxia means it's not about loss of motion over here, loss of movement over here. It is incoordination of the movement over here. Incoordination of the movement. Among them, what else you can say? So there's a terminology you must be knowing what is this? What is it?
Dysdiadochokinesia. Dysdiadochokinesia.
What is it?
Dysdiadochokinesia.
Okay. This diadochokinesia. Kinesis. So what is it? This diadochokinesia, what is it? Alternate pronation and supination. If there is a cerebellar lesion, he can't be able to do this alternate movement. So one is pronating over here, now the supinating is relaxing over here. Getting it or not? And whenever it is supinating, the pronator muscles are relaxing over here. So So this is the coordination maintained over here. Getting it alright? So that is the dysdynokinesia. And then followed by the other things are
Dyspepsia.
dyspepsia. What is dyspepsia means?
Not able to tell the distance.
Can't measure the distance.
Can't measure the distance. What distance, right? What distance? So if somebody is sleeping over there, so I have to measure the distance to throw the chalk piece over there. So how many feet I have to throw? That is the metria. What is it? The measurement. Okay. So if I am supposed to throw, how much distance is this one? How many feet is this distance? Right. Say you don't have any cerebellum lesions now. Count it and you know. Right? 25 or 10 feet. 25 feet. 70 feet. Okay,
70 feet?
10 to 50. So
Maximum 12 or 10 to 15 feet.
How many feet? 15 feet. 50 or 15?
15.
15. Okay, 15 feet. Roughly 15 to 17 feet. So this is the metria. That means he or she could measure the distance to the chalk piece over here. In case of lesion over here, dysmetria. This means obviously some abnormality over here. He or she can't able to measure the distance over here. Okay, any other? Decomposition. What is decomposition of the movements over here? Decomposition of the movements. So any music directors or choreographers over here? What's the name? Choreographer. Say it. Or musicians or not musicians, that music directors. Obviously, that's what I'm trying to. So to compose a music, what you're supposed to do, multiple tunes will be collected together or organized together, and a music will be produced over there. The same manner, for the dance choreography also. So I didn't know. So those movements, so those are coordinated, composed movements. Okay. So those movements will be lost because of the loss of coordination. That is nothing but the decomposition of it. Okay, I'm not going into anything about that. And then followed by nystagmus. What is mean by nystagmus?
Abnormal eye movements.
What is it?
Abnormal eye movements.
What?
Abnormal eye movements.
Abnormal eye movements. Pendular movement of the eyeball. How this occurs? So eyeball will be oscillating in this manner. Whenever you see a person who has cerebellar lesion, nystagmus, there will be vertical nystagmus or horizontal nystagmus. Generally, there will be horizontal nystagmus. Okay. So why this is produced over? Coordination between the lateral rectus and medial rectus. Whenever the lateral rectus is contracting over here, medial rectus must be relaxing on that particular eye over here. If both are not relaxing and contracting simultaneously, there will be incoordination over here. So with that incoordination, the eye can't be able to manage one direction over here. So whenever he is trying to move this side, automatically it will be moving to medial side over here. Whenever he is trying to move laterally, automatically it will move medial because of the incoordination between the lateral rectus and medial rectus. That is a nystagmus. And one more thing is the, what is it, right? Tremor. Intentional tremor. Intentional tremor means,
Do some work.
so in the Viva you will be doing intentional or resting tremor, right? In the Viva, unless and until you know everything,
Yes, sir.
if you know, for example, if you don't know, for example, an answer, so that is a resting tremor or intentional tremor, right? Resting tremor. Obviously the resting tremor, is it not? Even though you are sitting, you will be shivering to hold the bone. That is a, what is that? Resting tremor. Of course, you will be
But the intentional
later you will be holding, it's okay, but in front of the examiner, your hands will be shaking in this manner, right? Of course, that is physiological, not pathological. Okay. So intentional tremor means with intentional movement, the tremor will be produced because of the incoordination. For example, if I ask the patient to lift his hand, for example, this is an intentional movement over here. Okay. So what will happen because of the incoordination between the flexor and extensor muscles? He can't able to flex it in this manner. He can't able to extend it completely. So both will be moving in this manner. So partly flexion, partly extension over here. Okay, getting it over? This is the flexion and extension movement. So because of the intention of the movements, the patient can't be able to keep it in particular position in this manner. So I don't have any intentional tremor, right? I don't. Do we have intervention tremor or not?
No, sir.
No, no. Yes or no?
No.
Yes or no?
No, sir.
Do we have intention tremor or not?
No, sir.
No, no. Right. So these are the different things which you can see in the neocerebellum over here. Understood our different thing over here? Okay. Let us see the result of it.